Okay, so finishing up chapter 13, there's some principles of immunity that your book talks about. And to give a brief overview of what we're talking about, immunity is protection from potential pathogens, and that can be obtained naturally or artificially. So when you think about naturally, I want you to think about mechanisms that immunity can be acquired through normal biological processes, whereas artificial immunity involves the medical community in some way doing something to inspire that immune response. So to make a little more sense out of that, we can think about active and passive immunity as well, and how that relates to natural and artificial immunity. So when you think about active immunity, I want you to think about a person's body actually having the immune responses we've been talking about in chapters 12 and 13, rather than being passively given them by somebody else's body. So in active immunity, somebody can naturally acquire active immunity by actually getting sick. So you can get the chickenpox, for example, the actual illness, and you will acquire natural and active immunity and hopefully never get chickenpox again. Whereas you can also get artificial active immunity by getting vaccinated. So you can be given small pieces of a potential pathogen, probably won't get sick, and you will develop an active immune response. That's active artificial immunity. Passive immunity usually means getting antibodies from somebody else's immune response. And that happens naturally. A great example of that is a baby inside of the womb getting IgG antibodies across the placenta from the mother's immune system. Those antibodies are very effective in the baby's body, but the baby did not make them, so we would call it passive natural immunity. And then we can do this in the medical community as well, and often do. This person has an IV drip going of what is probably antibodies from perhaps somebody else's plasma that are being given to her. That's passive artificial immunity. So we're going to focus now on this idea of active artificial immunity for a little while. We're going to talk about vaccination. And just relating back to the very first day of class when we were talking about the history of microbiology, the idea of vaccination actually goes back, not in its modern form, but it goes back thousands of years to what was called variolation after the variola virus, smallpox, because Chinese people found that those that had survived um, smallpox actually had somehow developed some protection against them, such that you could grind up smallpox scabs from someone who had survived and administer them to somebody else and get some sort of immune response. Edward Jenner, remember, still trying to prevent smallpox in people, he took this to the next level because he found that a very similar virus, cowpox, was able to, if you inoculated people with little bits of cowpox virus, cowpox is not a severe illness, but is close enough in its antigenicity to smallpox to inspire an immune response that's effective and protective against smallpox. So this became known as vaccination because vaca means cow in Latin and Spanish. So vaccination became this idea of injecting cowpox into somebody to prevent a different disease. The basic idea behind vaccination is we want to administer something that looks enough like a pathogen. Sometimes it's the pathogen itself, but oftentimes it's little pieces of the pathogen, such that we stimulate a primary immune response. Remember, the primary immune response is the first immune response. It has usually quite a lag period, maybe 7 to 10 days. But it leaves behind memory cells, memory B and memory T cells, so that anytime the person sees the actual pathogen for the rest of their life, they hopefully will have the memory response to prevent actual illness from forming. These vaccines come in a couple different forms, and I do want you to be familiar with the basic idea of what we're talking about. Some vaccines are delivered as actual live pathogens. So these are actual active viruses, or in some case, live bacteria, but they usually are attenuated. Attenuated means somehow weakened. They're they're genetically modified or in some way, shape, or form changed so that they're not as virulent, and therefore we're not injecting, of course, we don't want to inject a powerful live or active pathogen into somebody's bloodstream. Um, these vaccines that are live and attenuated tend to have greater side effects, and side effects might mean fever, redness at the site, because when you inject a live but even a weakened pathogen, you inspire a much stronger immune response. So these tend to be very effective vaccines, but they tend to have some unpleasant side effects. So over time, they've been sort of phased out for, unfortunately, these other types of vaccines we're going to see that usually require more boosters, but don't have quite as many adverse effects. So you see here a single dose vaccine in these live attenuated vaccines. That's a good thing. That means usually you don't need to get lots of boosters. And every time that you introduce boosters, you introduce a reason for people not to stay up on their vaccinations. Some vaccines deliver whole pathogens, but these pathogens have been killed, or in the case of viruses, they've just been inactivated somehow, maybe chemically inactivated or heated up to the point where they're no longer active. So these are safer now, but they do usually require more boosters to keep up. Some vaccinations are called toxoid vaccines, and what's interesting about these is that what you are actually vaccinating against is not the pathogen, it's the toxin that's being produced. Okay, so maybe we could think of the tetanus vaccination as an example. We don't vaccinate against the tetanus bacterium, we vaccinate against the tetanus toxin. And that's, the toxin is of course the part that causes the damage. These usually require fairly common boosters. You probably heard that the tetanus vaccine, if we're using that as an example, about every 7 to 10 years you probably want to get a booster, because we're inspiring a weaker immune response with this inactivated toxin than we would if we were vaccinating with a live bacteria. Okay, continuing this idea, we can also use subunit vaccines, which are vaccinations that deliver not a whole pathogen or not a whole toxin, but little tiny pieces of a pathogen. Maybe just a membrane protein and a flagellum protein or something like that, just little pieces of an immune response. We try to pick pieces that are able to stimulate a strong immune response. Oftentimes, these do require some boosters as well. Actually, okay, so a growing idea is called a DNA vaccine. So this is kind of an interesting idea, although it's a little bit controversial. It kind of scares people a little bit. So we could actually administer the DNA rather than the protein of a subunit of a pathogen. So here we see, let's say this is the bacteria we want to vaccinate against. We could take one of the genes out of that bacteria and put it in a plasmid and actually inject the plasmid into a person. And a few of our cells would take up that plasmid and actually start making the bacterial protein. So this is kind of a recombinant DNA approach in which our body starts making this protein. This is very attractive because if our cells are making this protein, we're going to activate a very strong immune response to this particular protein that is not supposed to be there, but it does worry people a little bit. Here we see a number of different ways that these vaccines are administered, often by injection. There are also some that are administered via oral drops or nasal sprays. So there's a number of different pros and cons to each of these that you'll probably learn more about in your clinical classes if you are going into a career where you'll be administering them. A hot issue in vaccine discussions is a chemical class called an adjuvant. These are chemical additives to vaccinations that are designed to sort of hold the antigen in the injection site longer. So once the injection, let's say, is injected into a person's deltoid muscle, the adjuvant holds it there in a kind of a clump and allows the immune response to be stronger by allowing all that antigen to be in one place, so that our antigen presenting cells can pick up antigens and activate our lymphocytes. So the idea behind these is that they make vaccines more effective. Some of these are aluminum salts, and these are often the chemicals that anti-vaccination literature focus on as potentially dangerous additives. There is a lot of testing that goes into the safety of these adjuvants, and they use very, very small amounts. So as you are talking to people and talking to patients especially, please be aware of what this term means, because it is kind of a hot button issue. Vaccinations have to go through many, many years of safety training before they are allowed to be used. I don't think many people recognize how much safety trial has to go in before these vaccines reach the market. However, there is always a risk of adverse events, and adverse events is a scary term. Some of these complications are not very severe. For example, having a slight red spot at the site where the injection is, that's the most common adverse event reported to vaccinations. I would argue that's about the same level of adverse event that a paper cut is. However, some people do develop fever for a day or two, feel kind of lethargic, babies get crabby. That is actually a sign of a very effective vaccine activating a non-specific immune response. I would not consider that to be an adverse event, but it has to be reported as such. And so the statistics behind adverse events are sort of inflated by these less severe responses. However, there certainly are a small number of people who develop severe adverse effects. A lot of those are people who have allergies to something in vaccines, like, for example, egg particles that can't be completely removed from some vaccines. A fairly famous study in 1998 tried to link receiving the MMR vaccine in babies to autism. This was a very poorly done study that had data that's been shown to be made up. The primary author spent some time in jail for fabricating his data. However, the idea of vaccinations causing autism has remained even after this study was discredited, which has led to, unfortunately, reduced vaccination rates. Some of the data about vaccination rates and illnesses shows that 1998 study really did have an effect on vaccination rates and cause a comeback of some diseases that had been nearly eradicated, like measles, for example. This is a study looking at the incidence of pertussis in the United States, and we note here the arrow where that study by Wakefield and his colleagues was published. We see a huge jump in pertussis cases due to largely people not following through on vaccination. Thankfully, that trend has reversed as people have realized that, hey, this is a pretty severe illness that actually can kill quite a few babies, and we can prevent it. So the price of making the choice to not vaccinate basically includes return of illnesses that we have had largely in control for many, many years. Herd immunity is an important term that relates to the fact that if many people are vaccinated, and then the magic number is about 85%, if 85% of people are immune to an illness, the other 15% who aren't vaccinated are very, very unlikely to experience the disease because they're going to be surrounded by protected people in the herd. We're not at 85%. As I published this video, we're about 78% or so of vaccination rates for many childhood diseases. But that is always what we're pushing for with vaccination. Protecting yourself, but also protecting the people around you.